I think we have a very fantastic session regarding how we will assess the lung nodules when it comes to in routine clinics. From that, if the lung nodule appears suspicious and it turned out to be cancer, how we will stage those tumors that we have to actually see. And the main thing is that there is a lot of team that is actually required in the assessment of all these lung nodules, and here is our team. Maybe you are also having your own team which will communicate in these sessions. Life is not that simple always, because it is much more complicated. We have lesions which may mimic like lung cancer, and we have other comorbid conditions like emphysema, other things, tuberculosis coexisting with these conditions, and that's how the routine thing that we are talking about. So the main thing is that once it is known that there is a malignancy, we have to assess that whether it is loco-regionally involving some structure or it is having some distal extent as well, and whether we have to prove it with some kind of image-guided biopsy and then stage, and then we have to mention about the associated comorbid conditions, because there is a lot of thing that comes into the mind that whether the patient might go for a surgery or it might go for a radiation, RFA, or a palliative therapy, targeted therapy, immunotherapy, or directly an upfront best supportive care. So coming to the local part of the staging, that when we are talking about the T descriptors, that is the CECT thorax that we use to assess the T descriptors, and you can see that we can see there is a nodule that is sitting here, and one can go from either from the T descriptors towards the N descriptors, and the N descriptor, T means that tumor locoregional extent, N means the nodes, and M means the metastasis. So this is the nodule, and whether it is associated with any metastasis, directly it becomes that it is may not be curative if it is having extensive metastatic disease. So once we know that the size makes a difference, so any incremental increase in the size, the 5-year survival is going towards a decreasing trend. Apart from that, there are many other things that we need to know, that whether the relationship with the bronchus, the carina, what is the relationship with the viscera and the diaphragm, vertebra, and any other things, whether they are having satellite nodules, and whether they are into the same lobe or the different lobe, everything makes a difference, and it will upstage the disease. So it is not only the size of the tumor, it's about the relationship of the tumor with respect to the pleura, with respect to the mediastinum, with respect to the bones, and whether there is any additional, everything encompasses the T stage, it might be upstaged because of that. So when we talk about one is the size, and the other thing is that if it is involving the viscera, it's directly become T2. If it is involving the vertebra, it will become T4. If it is having mediastinal infiltration, it again become T4. And if it is having satellite nodules, it become T4, and things like that. So coming to the M descriptors, I think it will be taken care by Nilendu sir in his talk. So it encompasses the whole body PET-CT plus MR brain, when we are actually trying to figure out where exactly it has gone out of the thorax and where it is actually lying. So usually it is the PET-CT, CECT plus MRI brain that we are used to do, and we look at the PET-CT to see where exactly it is spreading. The brain is having high FDG uptake, and that's why sometimes these lesions can be missed, because sometimes these lesions could be very, very small in size and having a subtle leptomeningeal enhancement which can be missed on the CECT. So MRI brain with the contrast for the asymptomatic brain metastasis is used for staging these lesions. So these could be the variable presentations that we can come across. So we can have necrotic metastasis, we can have small nodules like this, which even not causing any kind of edematous structures, or we might have just leptomeningeal disease without any neuroparenchymal, other neuroparenchymal metastasis. So these can be seen. It could be solitary, it could be multiple, and actually it will affect the treatment in a significant way. Then coming to the nodal staging, it is about N descriptors, and that usually with the either we can go for the EBUS TBNA or plus minus mediastinoscopy, depending upon the expertise of the center. So if you want to stage the mediastinum, it has to be with the invasive mediastinal sampling, and if that comes negative, it could be done with the mediastinoscopy. So if we talk about, suppose this is the tumor, how it is going, and that we want to know that usually it will go to ipsilateral, then subsequently it go to subcarinal ipsilateral mediastinum, then the contralateral mediastinum and the supraclaviculus, and that's how it is getting its upstage done in these kind of scenarios. There may be some nodes which, if they are present in other locations, it make them metastatic, because these are not the routine loco-regional site if it is not involving the chest wall or maybe the mediastinum. So if these nodes are involved in an entirely pure pulmonary lesion, then these are going to be the metastatic sites. So if the no nodes are there, then definitely surgery is one of the most feasible option. And if it is ipsilateral, not significantly bulky, it can be done with the NSCT and surgery. And if it is contralateral, then we have to decide if it is into the spectrum, CTRT can be done, or maybe if that is not the case, that maybe the palliative chemotherapy. So something like this, if it is very early, it might throw just ipsilateral settle metastasis, but if it is too large, it might throw the contralateral and supraclavicular metastatic disease. The need for invasive sampling, I think sir will stress on that, because even though PET uptake might have a chance, high avidity might have a chance of 18% of these nodes as a granulomatous, and that's why invasive sampling is required, just to understage whether we are understaging or upstaging the disease in a better way. So if we want to summarize the staging, we need to have a detailed clinical history, physical examination, chest X-ray to rule out whether there is any disseminated malignancy. Thoracic and upper CT will confirm that there is a lung mass, whether there is any complications that are associated or there are any synchronous lesions that are there. Once the disease is localized and we want to treat with a curative intent, we have to do a distal metastatic workup with the PET-CT and plus MRI brain to confirm whether there is any occult metastasis lying somewhere, or there is an occult metastasis or asymptomatic metastasis that is there in the brain. And once we know that there is no occult metastasis, mediastinum looks imaging-wise okay, we need to do that with the endobronchial ultrasound assessment to look whether these nodes are actually positive or not, and then with the mediastinoscopy, and then finally the resection of these things. So just to take home points that we need to make our own small MDTs, and we need to know that positive nodes on FDT doesn't mean it is going to be metastatically positive, or negative doesn't mean that there is no metastasis in these nodes. And the contrast enhanced MRI is the choice for the detection of the metastatic brain lesions, and it is a part of staging to pick up the asymptomatic brain metastasis. And we need to know that apart from surgical, there are non-surgical options in the node-negative lung cancers when there are a lot of comorbidities like the RFA and the SBRT. So thank you so much. And now I would like to invite Nilendu sir for his expert talk on the metabolic imaging, how it is changing the scenario in the lung cancer management. So over to you, sir. Thank you so much.